Thank you. Good morning again, everybody. I hope the morning's gone well, and thank you very much for coming back for this second presentation. As Dr. Louis has indicated, we're really going to look at taking that information we spoke about in the first talk and some of the other things you've heard this morning and will hear this afternoon, and put them into a context where you can now go back to your clubs and say, this is how we're going to do it in our clubs, and how we're going to tie in with the Aspetar sports-related concussion clinic. So it's really where we go from here. Again, the disclosures, which are the same as this morning. So I'm going to start where you start as team doctors and physiotherapists and assistants, etc., and that's on the field. I think that once you've identified a concussed player or a player with potential concussion, the first thing is they need to be continually observed. So someone needs to be with them to make sure that you can observe what happens to them, because very critical to the decision-making process is whether they improve rate over time. It will largely determine where they go from your care on the side of the field. Obviously, they need to be rested from exercise, and that duration will depend on the findings in the coming days and weeks. You need a process to confirm the diagnosis. And an important point is that you don't need to confirm that diagnosis in the immediate period after the match, because sometimes concussions evolve over a period of a couple of days. And it's important to look at a suspected concussion, get them into the process without necessarily having to confirm the diagnosis or the prognosis. So I think that's critical to your decision making will be to decide two things. Is this a more serious case that needs admission to your hospital neurosurgical unit together with imaging, or is it a case that can go into home care and be referred from there to the sports concussion clinic? Whatever you do decide, they need to be referred one way or the other. They need to be pushed into the system. And also, as the clinician working with that player, you need to keep being part of the management. So it doesn't matter whether Dr. Louis sees them at some stage or they go to the neurosurgeon, later go to the hospital, to the clinic. You need to be able to be in touch and follow that process as part of your serial care. Because concussion is all about repeating the assessments and monitoring the trends, which should be improving so that they can get back to sport. So these are the steps that I think are important. The first is to on the field, identify and remove them. The second is to do your initial assessment using a SCAT5 type tool on the side of the field. Then to let them get more formally clinically evaluated at the concussion clinic, to then follow them up as many times as is needed until their condition resolves, and then to be part of a return to sport process. So those are the key elements, I think, that you need to follow in every single case. Now, I think some of the other speakers will have covered some of these, the red flags, the indications for being a little bit more acute in your management and referring them to a neurosurgical center for urgent scanning and observation. And you will have seen these before: the headaches that worsen, the severe neck pain, the drowsiness, the inability to recognize people or places, consciousness that deteriorates, confusion, vomiting, slurred speech, focal neurological signs, weakness or numbness in the limbs, unusual behavior, and seizures. So I think if you keep those in the forefront of your mind on a little card that you can refer to, you will know which cases are likely to be more severe. This does not apply to most cases. Most cases will not present with these. Most cases of concussion, even those that lose consciousness, that have amnesia, tend to improve and stabilize. These are the cases that you're going to look at getting more urgent attention to and referring to a neurosurgical center. But you should not be doing that as a matter of course. As a matter of course, players should be evaluated on the side of the field, monitored for a couple of hours, and then usually referred home with a caregiver. That would be the normal process for you. But there are cases that require those more specialized care, and these are the indications on the side of the field for you to do that. Also important to understand why we look for these. And the reasons why we look for them is that concussion may mimic other much more life-threatening conditions. Concussion should never be a life-threatening condition if it's treated properly. But if you have an intracranial bleed or cerebral edema or a fracture or something which is mimicking concussion like a stroke, carotid artery dissection, an epileptiform type condition or a severe neck injury, those can deteriorate quickly and those can be life-threatening. So that's why we look for them, because not every collision and not every head injury is at the milder end of the spectrum. Some of them start that way and deteriorate quite quickly, and you need to be aware of the signs, and you need to be able to monitor them quite quickly and efficiently to be able to refer them. And that process may happen even over the next 48 hours, and that's why it's important that you give this information to any caregiver who's looking after what looks like a mild head injury, so that they can refer appropriately if the condition deteriorates. This is a very, very busy slide, but it really is taken from the Aspetar sport-related concussion program Flowchart, which Dr. Louis has put together. And it's a very, very good document, I think, and it's one that needs to be on your desks. It needs to be one that's up in your office and perhaps up in your facility at the sport as well, so that you can continually remind yourself of how to act. And we're going to go through each of these stages because this is going to be your go-to document that you need to work with in terms of guiding your management. So the first step is really to exclude any serious head injury and to determine whether the injury you're dealing with is in the high-risk red category or the lower risk category, which has a very different management protocol. So I think you're probably all very well trained in the Glasgow scale and identifying the levels of Glasgow coma scale, and anything that is below 14 would be an indication that this is 14 or below is more of a more serious injury. Your on-field management is standard in terms of head and neck injuries. You need to do your A, B, C, D, E for first aid, as it were. You need to, particularly in players that have lost consciousness, stabilize the cervical spine. You need to remove from the field of play and do that with the neck stabilized if necessary. And you need to observe them, communicate with them, reassure them, and continually observe and report on those vital signs initially. Again, I will emphasize that most concussions, you will, in your initial assessment, be able to exclude any form of Glasgow coma scale compromise. It's still important that you communicate and observe them, but you shouldn't be having to panic about their deterioration in condition, because most of them will actually be improving. Those that don't, you've got to move into that high-risk red category, and you've then got to look at all of those factors and say, this is a case that I need to actually refer to the neurosurgical unit because they are high risk. And again, those are classically those red flag signs that we've looked at. And I would add to that any sort of deterioration in condition or any case that you're just not comfortable with, then you would err on the side of caution. But you don't want every time that there's football happening, in Doha, that the neurosurgical units are flooded with cases because they've had a knock to the head. Most of them will not have to go that way. Most of them will be lower risk, where the Glasgow coma scale stabilizes at 15, there's no deterioration, they don't have any of those red flag signs, But they will have signs, exactly as are listed there. They will be tired, they will have nausea, they will be dizzy, they will have some headache, they will have some behavioral change and maybe even some loss of memory. That is nothing to panic about. And the more experienced you become with these, the more you will know that you can monitor these for a couple of hours, inform the person that's looking after them, and get them back home with a view to following up in the day or two to come. Now, that's an important understanding to initiate your process. Once that has been initiated, then depending on where they go, you can decide, obviously, if they're high risk, it's taken out of your hands for a while. But that doesn't mean you don't communicate. And I think it's very important to communicate with the neurosurgical unit on the one hand, the radiologists as well, and then on the other hand, to communicate with Dr. Louis and say, we have a player who had a head injury that I was concerned about. I sent him through to the neurosurgical unit to be scanned and admitted. This is his name, and it's a case that we will need to follow up later. So, that is an important part of the communication, although they may not go into the sports concussion clinic immediately. So if they warrant admission and scanning, we'll send them to the unit. The unit will then decide if there's obviously an abnormal scan that's treated as more of an emergency, and the neurosurgeon will see them and manage them accordingly and only discharge them when they're ready, in which case they go to Aspetar for management. If the scan is normal, and most of the scans will be normal, they will be monitored for as long as necessary, and then they will be discharged and again get into the Aspetar type of system and follow the normal return to play process. Again, to emphasize, that is the exception. Most of them will go along the screen stream where they will be monitored by you, and if after 4 hours after the injury they are looking much better, then you then discharge them home and you give them the correct information, which we'll go through now. You are clinicians. You are trained to make clinical judgments. You don't have any special machines or tests on the side of the field to determine whether that player is at risk or not. So you really need to practice and become comfortable with clinically evaluating these players, and the SCAT5 will help you do that. So if they are more alert, if their behavior is returning to normal, and they are cognitively able to respond to you, the trend is one of improvement, and none of the indications for a CAT scan exist, then you can feel comfortable that having monitored them for a few hours, you can send them home. Very importantly, they need to have a responsible person with them who understands the necessary follow-up and the necessary observation, understands the ability and access to the emergency room if necessary, and they have the correct discharge advice, which we'll go through now, and that you need to provide in a written form. So they need to leave you with that written advice sheet as to what to do and what not to do, and they need to have the discharge summary and SCAT5, which you've completed. And once that's happened, they can then follow up with the Aspetar sports-related concussion clinic, which they all must do. And I think that's very, very important. And I think having this sort of system should be of great comfort to you as clinicians, to know that you have both a system for more acute, severe management, and you have a system which looks after most of the other less severe cases. And I think that's something that's important. This we've gone through in terms of the initial on-field observation, and this is really first triage protocol to exclude the more serious head injuries. These again relate largely to red flags and those indications for management or acutely and referral for imaging and neurosurgical opinion, and those are the cases which will apply these are the situations that will apply normally, where most have settled down, there's no indication for referral for scanning, and they're sent home with those discharge criteria. Again, I must emphasize the need for monitoring, either in hospital or out of hospital, initially by you and then by a caregiver, and then for follow-up. Every case must be followed up. So that's very important. And I think your players will feel a great sense of comfort if they know that you're managing them together with the Aspetar team. When there is a high-risk case that's identified, I think the first important intervention is that CAT scan. So it's very important for you as a clinician to follow up on that and make sure that when they're referred to the hospital, that scan is done and that you know the result of that scan. Because if it's an abnormal scan, it does become a neurosurgical emergency, and you need to make sure that they are channeled in the right direction. Again, that would be very, very, very unlikely. If we see 200 cases in a season, in our clinic, maybe one of those falls into that category. Very unusual. If the CAT scan is normal, it's important that you know that you give the coach and the player that feedback, that you give Dr. Louis that feedback and say the player will now be entering into the normal concussion management system. So, as I say, most of them will to that green management screen. In other words, monitored field side and referred home with a caregiver. It's very important that you put together, if you haven't, a concussion advice sheet, which gives them information as to, firstly, what are they dealing with, because concussion is a difficult thing. They can't see any sort of wound which they can monitor. They may or may not have had a scan, which give them more information, and they need to understand what is happening to their brain. They also need to know what to look out for in terms of potential deterioration, and they need to know what to do, both the injured player and the caregiver. And the type of advice that I think is important is, what is concussion? What should I look out for? Is it okay to sleep? And you need to discuss that with them, that yes, it is okay to sleep. In fact, they need to sleep and recover as long as they've been assessing the build-up to that for a few hours. Can they take something for pain? And the answer is, of course, yes, they can, but we usually prescribe only paracetamol, not anti-inflammatories. What should they avoid doing? They should avoid taking caffeine, other drugs. They should avoid driving until they've been given the go-ahead. They should avoid alcohol, taking of sports supplements. They should avoid looking at computers and screens, and they should avoid exercise until they've been given the go-ahead. May they eat? Of course they can. If they're nauseous and been vomiting, they should be careful about the amount that they're eating. They should be given a contact number for the emergency room and for yourselves, and they should be given the correct referral to Aspetar, to the sports-related concussion clinic, with their discharge letter and the SCAT-5 that's been completed. So this is really a summary of your complete concussion care for nearly all the players that will be sent home to the caregiver. This is again a summary. Remember the provisions for discharge, the responsible person that's available to take responsibility to communicate with you, the ability to return and have access to emergency room and you if the symptoms deteriorate, and the discharge advice which they need to understand. That advice includes the patient advice sheet, the discharge summary and SCAT-5 for the Aspetar clinic. Remember that acts as the initial assessment, so it forms a type of baseline, if you like, that can be compared to their follow-up assessment, so it's very important. And then all patients to be referred within 72 hours. At the clinic, they will undergo sequential follow-up. In other words, they'll be assessed. They will undergo a repeat symptom analysis. They will look at their general and neurological evaluation. They will do some cognitive tests verbally, and they will do some follow-up computerized tests at that stage. And they may be called back to further evaluate their progression until they're ready for a clinician-guided return to activity and sport program, which you will be part of. So I think very important, sorry, there's a spelling mistake there, personnel, it should be personnel. The team medical personnel really hold the key to successful concussion management. You are key in differentiating high risk versus low risk, identifying the red flags for admission and imaging, and referring to and liaising both the hospital and the Aspetar sports-related concussion clinic. So even though the player has left the field, as the team's medical support, you still remain critical to the communication follow-up. They need to be followed up regularly and more than once. They need to be returned to sport with your assistance. And as I mentioned, that education process that we discussed in the first talk is very, very important. So I hope we've kept it simple and that you understand these sort of principles, and very, very happy to take questions on any of those points now, that we've discussed.